Hello everyone, this is Sadhana Alangar, HL7's Director of Education. Welcome. FHIR, what's in it for healthcare providers? We have a distinguished panel to discuss this topic today. Each of our panelists has over 15 years of experience in healthcare technology. Dr. Michael Ash is the Executive Vice President and Chief Transformation Officer at Nebraska Medicine. James Buntrick is the Vice Chair of IT Enterprise Technology Services at Mayo Clinic. Kalyan Pamarthi is the Product Management Lead of Healthcare and Life Sciences at Google. Our moderator is Jeffrey Springer. He is the Senior Vice President of Healthcare Solutions at CTS Tech. At this time, Jeff, if you're ready, I'm going to hand over the program to you. Hi, Jeff.
Yeah. Thanks, Sadhana. And good morning to everybody. And I see somebody is coming from Denmark, so good afternoon to anybody who's a little further away. I'm excited for today's panel. The thing that I'm particularly excited about, not just the backgrounds of everybody, but the mix of backgrounds. So Dr. Ash, clearly medical doctor, comes with that clinical background, but also an IT background coming from Cerner before he was at Nebraska with a whole bunch of patents to his name. Kalyan from Google, getting a broader industry perspective across the industry, working with a number of players to understand what's going on from the broader perspective. And Jim, clearly the IT perspective, but leading up innovation at Mayo as well. So between technology, clinical, strategy, I think we'll have all of these things covered. So very excited to hear what our panelists are going to talk about today. As we enter this topic, I'd like to say a little bit about FHIR and introduce the topic. In my background, I found healthcare data to be an ugly, nasty place. And the industry has tried to fix it many, many times over. I was part of the very first HIE in the country and the world and learned just what a disaster healthcare data was and how creating standards out of it was difficult. Then as we fast forward to today, people spend hundreds, if not millions of dollars trying to interconnect different systems, and it's always in a rush. It's always one-offs, and it prevents a broader strategy. So I'm excited for this conversation and for FHIR in general to transform the way we think about data, the way we think about our data strategies, and to hear Dr. Ash, Kalyan's, and Jim's perspective on this. And so with that said, let's go to our first question. And what we'll do is we'll lead off each question with one of our panelists to get their perspectives and then get the other panelists to give their perspectives as well. All right, our first question is, how has interoperability helped manage the COVID-19 crisis, and how would FHIR make a significant difference? For this question, let's start off with Dr. Ash.
Thank you, Jeff. And good morning, good afternoon for the attendees. And so for us, originally COVID really impacted people across the state. So we're a very broad state, it takes about 7 hours to drive across. And we have a number of meat packing industries, as one might expect. And within that, the employees come from all over the world. And so our originally admitted patients with COVID, more than 65% of them, English was not their primary language. And the number of languages and dialects was over 24. And the ability to communicate with people coming in, to get past history, find out medical conditions, comorbidities, was very challenging, when a number of times it would be more than one patient that would be transferred. Fortunately, we have a very large state HIE, and we were able to pull information from those systems to get that background. So not only stabilizing the patient, but designing care intervention and longer term plans. And as well as we needed to quickly, once they were stable, move them back to regional and community health systems. Where I think FHIR would help is with anything is the level of granularity and standardized information that could pull into a more seamless workflow. It was wonderful that we could look at that information in a compartmentalized way, but if it were more seamless, would allow additional decision support. I'm also the Vice Chancellor of IT for the University of Nebraska Medical Center, and we're working at how can we do research now post-surveillance through our IRB processes, and having even more structured information would help speed up that process. And right now, when we're talking about a condition none of us even heard about a year ago, every second, every minute that we can speed up is valuable for not only the treatment, but also how do we look long-term at better management and prevention. Thanks, Jeff.
Thanks, Dr. Ash. So as others think about this, Jim, from the Mayo perspective, Kalyan from the industry perspective, thoughts on interoperability around COVID and how could FHIR have changed our response around these types of things?
Yeah, thanks, Jeff. This is again Jim from Mayo Clinic. Kind of echo what Dr. Ash said. I'll add a new perspective from how we did use FHIR. So as COVID was emerging, our organization, which is located across 5 different states, started to prepare for the COVID surge. So how would we do patient management through our mini hospitals and beds? At that time, we had an internal application for critical care that we were able to quickly modify using FHIR resources to provide kind of just-in-time views of critical ICU units, critical care units, and really show an overall pulmonary function status. This work was completed over a 3-week period in the midst of the COVID crisis, and it really shows the power of being able to adapt an application using FHIR, in our case, version 3, release 3, and add in some additional elements to capture more information about the patient, the location, their condition, the COVID testing and the COVID testing status, and overall kind of COVID impact. And it really upped the situational awareness in our different hospital geographies. In our case, we were fortunate that that initial surge did not reach its true pinnacle that we worried about. But nevertheless, we continue to incorporate that into our day-to-day work going forward in our hospital setting. So I think that's a great example of, I wouldn't call it innovation in the sense that we were applying the tools of the trade using standard technology that could tap into our real-time data feeds from Epic, as well as complement some of our historic feeds of our legacy EMR. It was a great success. I think it was very impressive, the speed which we turned that around, partly due to the standard that we used.
Great, thanks, Jim. So let's go to our second question. How has your interoperability journey been so far? And what would you highlight as your key challenges, drivers, and outcomes? And as we think about this question, you know, Dr. Ash, Jim are looking at this from a single system. Still impressive what they've done, and we'll hear more about what they've done there. But Kalyan brings a unique experience with looking at multiple systems. So let's start with Kalyan. As you're looking at the industry and seeing what have multiple players done and what have their challenges been, as well as some of their highlights.
Yeah, absolutely. Thanks, Steph. Good morning, good afternoon, good evening to everyone from wherever you're joining us. So I'm part of the product team at Google Cloud Healthcare. And so Google, we work with a lot of different provider systems on their interoperability initiatives. And so my team has an interesting vantage point to how customers are approaching their interoperability, both pre-COVID, but also the changes in strategy as part of COVID response. So Google has been involved with healthcare interoperability for a number of years now. Right? So our role as a technology provider is to be an accelerator or force multiplier for various healthcare organizations who are thinking about their data strategy and interoperability. So we partner with providers, payers, ISVs, and many other healthcare technology companies in their journey of thinking through what is the right data strategy. Should they be building systems on the cloud, on-prem, but also like what are the use cases, right? What is the short-term use cases versus what is the longer-term strategy on interoperability? We believe that the cloud is the place to develop and deploy interoperability solutions really quickly. So healthcare organizations don't have to worry about the underlying infrastructure, but can actually focus their strategy and execution on getting their end user applications up and running really quickly. So within Google Cloud, our primary surface for healthcare interoperability is our Cloud Healthcare API, which is our fully managed service for bringing in lots of different types of data, HL7, V2, FHIR, DICOM. And this is core to our interoperability strategy, right? Allowing different healthcare IT systems to talk the language of interoperability. And then providing our customers a tool set to very quickly develop applications, but also think about the future in terms of artificial intelligence, machine learning applications that they want to unlock on this data. Now, we've been champions of FHIR for several years now, right? We have a very active role in the community. We're on the FHIR working groups. All to say that we've believed that FHIR will be the common standards, common language for interoperability, and we've seen that across our many customer conversations over the past couple of years, more so this year, and particularly as part of COVID response, right? So we're all in on FHIR. When we think of FHIR, you're thinking of I'd say the three I's of our strategy, right? So one is implement the standard. So there's a lot of different pieces of the standard in terms of resources, operations, functionality that we could support across use cases. And so we spend a lot of time and effort thinking about how do we implement pieces of the standard that help our customers in their interoperability journey. The second is about influencing the FHIR standards development and working actively with the community, making sure that whatever we're hearing from our providers, payers, and others is shared back with standards development organizations. So work together, making the right choices around interoperability. And the last thing, and this is really important for many of our use cases that we're seeing in provider systems, is it's not only important to bring the data in and store it in a format that is standardized, but also connecting it with other technology components. For example, with data warehouses for analytics and reporting. We saw this quite a bit during COVID. When healthcare organizations were forced to rethink their data strategy, right? I mean, where are the various data sources? Pulling data from EMRs, lab systems, radiology systems, and then very quickly having to get them into a common format and exposing them to the various applications. And COVID-19 reporting, monitoring dashboards were really important at that time to keep track of what's happening. And so this is that whole end-to-end use case of interoperability was really important to COVID. So we saw a lot of our provider customers quickly wanting to pull together the really important data sources, build dashboards, and also expose it to, like Dr. Ash said, for researchers to be able to do analysis afterwards, where concepts like de-identification, natural language processing become really important. So when we talk to customers, we see two key business drivers typically. The first one is provider organizations wanting to move from a collection of systems of record, right? So these are EHRs, PACS, lab systems, etc. that work in specific areas and drive specific use cases, but are not best equipped to move data in and out and put them in a common repository. And so moving from those systems of record to systems of engagement, so these common longitudinal clinical data repositories where researchers can build applications, operations teams can build dashboards. That is the longitudinal clinical repository that we believe is going to drive the future of many of these interoperable applications. And this is in many ways a strategic goal for the organization, right? Interoperability and having systems connected and talking is usually the first step. And so the choice for many of our provider partners and customers is, do we do this in-house? I mean, do we build a new data schema for this? And thankfully, FHIR has solved that, right? I mean, there's no need to create a new data definition and data schema. FHIR provides that. There's also standard APIs that can be used. So any of the developer teams trying to come up to speed with these applications now don't have to learn a totally new data format. And so related to that is data interoperability, getting systems together, connecting the data is the first step. But truly, the goal is building these intelligent applications over time and using, for example, de-identified versions of the same data for building machine learning models and to improve quality of care. Right? So our partnership with Mayo Clinic is a really good example of that strategic view towards interoperability. The second business driver that we see is the speed of execution. Right? I mean, provider organizations want to meet some very specific use cases and want to get up and running really quickly. Like Jim said, in a matter of weeks, not months. Right? And again, the COVID-19 response was a great example of how provider systems can go from identifying a use case to setting up an infrastructure and seeing the analytics in about 3 to 4 weeks. And this is hard to do with more traditional on-prem systems where data is locked in. And so, we had another use case. One of our other large provider customers, they were trying to do COVID-19 reporting as well. And in about 3 weeks, they got set up with sending millions of HL7 v2 messages transformed into FHIR. And then setting up analytic systems on that FHIR data. Now, this would have been really hard to do without FHIR as a common data standard and using a set of managed services. And then finally, there's the management of privacy, security, compliance, and interoperability. All of these things to be taken into account while building an interoperable system.
Thanks, Kalyan. Dr. Ash, Jim, any additional context around this question?
I can add just a little bit. So obviously we at Mayo are very committed to interoperability, really being able to share data across organizations. We focus on complex care, so often we're dealing with referrals. So our journey, I'll kind of split into two quick highlights. In about 2012, we decided to go to one electronic medical record system. We operated 4 different medical record systems. And at that time, interoperability was around direct and connect, and its value was mixed. Fast forward to implement one version of Epic, one medical record, electronic medical record across all Mayo campuses and hospitals. That increased its value, not just from an internal use, but also leveraging some of the Epic CareLink and connectivity tools that has. And so we've seen a remarkable increase of satisfaction with our providers being able to get outside records quickly for the patients before them. FHIR, we've also been very committed to the FHIR journey. Early on, those early specifications were good, but they often lacked somewhat the specificity to map the right elements. And so we had a few false starts in the beginning. This is circa 2013, 2014, but fast forward, as part of our Epic convergence, we implemented FHIR resources on top of all our legacy EHR data. So for our historic viewer, we call it internally, data that's not formally loaded into our Epic system, we provide a smart and FHIR-based app running on FHIR resources. So that's continued the maturing journey of us. So the mix of legacy data plus new data being generated out of Epic, we've seen the value of FHIR. We're also very committed to, of course, the Argonaut community, giving guidance, and feedback to use cases that we think are important for our needs, but obviously it's a community input as we advise the standard. So we look forward to more work here with FHIR, but obviously we're highly committed.
It's very interesting how you brought different third-party applications, whether it's just Epic, and then we'll get into later in this conversation how you deal with a variety of different third-party applications and that interoperability as we go through that. So I think that actually brings us nicely to our next question. So we can go to our next question. How has FHIR changed your interoperability strategy, and does it have an impact on business, clinical, and IT strategies? How are providers tracking towards the regulatory compliance ONC and CMS? Dr. Ash, why don't we start with you on this question?
Thanks. I don't think you realize how important your clinical systems are until they go down. And I don't think you realize how strategic they are until you look at merger, acquisition, and affiliation. And so if you're on a Epic system that allows you to do Community Connect, where you extend your version of Epic, there's a tremendous benefit to getting that acquired organization on a similar system, but there is tremendous cost. And so if you look at those M&A partnerships, if these systems had improved interoperability at the level of specificity and the application development that Jim is talking about, it would allow us to focus on what's most important. So as a physician, I'm also over our clinical effectiveness and our quality and our safety. And how are we using technology to really impact the care and quality versus ripping out systems and replacing systems at tremendous cost and taking years to replace infrastructure, for the most part, is relatively commoditized across systems. Looking at a Google representative, Google Docs is very, very good. Office 360 is very, very good. Why should I have to rip out one and replace it to be able to focus on extraordinary care? And so I think as the FHIR journey, as the standardization, the use of ontologies and terminology sets, that we can focus on what's most important, we'll see continued improvement. And the ability to coordinate care across a larger set. And so our mission will be able to focus on care versus our business driving us to spend money ripping out systems that were quite functional yesterday and will be quite functional tomorrow. Thanks.
Yep. No, so that's very interesting. Let me ask you a follow-up question related to that. So in terms of systems that are functional, but you're leveraging value from them due to FHIR, what about systems like HIEs that are out there where you already have the data aggregated to some extent community-wide, whether they're local HIEs, state HIEs? How would you integrate that into the strategy? And as we talk about, HL7 version whatever, or CCDAs, how do you incorporate those into the strategy from interoperability? So you're talking about a transitional state where you're connecting those, but how do you think about infrastructure that already exists into that broader strategy?
Yeah, there's a lot there, and there's a lot of different directions that we could go. But I think from one is application development around specific use cases and workflows. And so the data may reside, but it may not be at a level of even specificity or granularity that I can focus on application development. So as an example, I referenced before a very broad state where we're the principal academic medical center, the #1 hospital on rankings at least. And so how can I do a better job deciding when individuals can receive care in situ in their regular, in their originating organization, or when do they have to transfer? And how can I use that? So how can I put in, everything use PMML, predictive modeling markup language, across a more unifying data set? I should be able to assign agents to help determine if a patient is at risk at sepsis, and then use PMML, who would do best to transfer to our organization. Our sepsis rate for around some of the conditions is around 0.2, and it's absurdly low. And so if you look at other organizations, their expected mortality rate may approach or exceed 1. I would love to use some of our predictive modeling. I would love to use some of our early detection. I would love to use some of our 24/7 capacity and improve the care across our state. And the HIE may have some of that information, but it's not real time. It's not at a granular enough level that I can run decision support. And it's not aggregated in a way that I can look to say, what is the help for sensitivity and specificity across my state? What are the most important indicators that say one patient is going to do okay and another patient isn't going to do well? I hope that got to your question, Jeff, but I would love for others to contribute.
That's fascinating. So let me ask a follow-up, and I actually will point this a little bit to Jim as well in my follow-up. So I'm envisioning a world where you can take data and regularly communicate a view of a patient or a visit or encounter, whatever it is, across multiple sources, and then use models, as you were saying, to predict things, i.e. sepsis or other types of events that are out there. As the industry looks at this, so could we create an industry acumen around, hey, I have a better mousetrap. So Mayo builds a better mousetrap around something else, we find out, and we then leverage that as an industry to then improve care rather than having to rebuild all the time and treat FHIR as an interface that could then share concepts across providers that we find really effective. Do you envision a world where the healthcare community starts to share differently based on having better interoperability across these topics? And then let me just add one little additional question in here. Also talk about mastering that data across the system. So I know within Epic, for instance, and you're both Epic customers, they are able to identify patients across systems with EMPIs. But as we look across different systems and across different contexts, does that become more and more important, and how does that come together? So Jim or Dr. Ash. Yeah, go ahead.
I'm
go
happy
ahead, Dr. Ash.
Jim, but I'll comment real quickly. I think that's one of the visions, is how can we use the collective learning? How can we use the collective data to have better insight and understanding of what's going on? And so in medicine, you're either born with it, your genetics, or you're exposed to it, your environment. And then how can I bring this information together with the appropriate context? And context could be inclusive of geospatial identifiers. If you look at multiple sclerosis, there is known geographic higher incidences. People, have higher indications of a condition like that. The same is true for anything that we want to talk about, lead and, water and water contamination as an example. So across that spectrum, the more information that we have and the more that we can pull it together, the better that we understand not only the human condition, but the condition that the person is facing at that moment in time. And so I think that was the vision, maybe even for the original RAND and high tech and other, of getting people on these digital systems with a goal of, let's use all the data that we can to have a better understanding so we can be much, much, much more precise and much, much more efficient in our decision making of what's going to work best for this person at this time based on the data from millions of people that have gone through similarly. Jim?
Yeah, thanks. I think one thing I would add from a perspective, so obviously FHIR provides a solid foundation. It doesn't solve all interop issues, but it provides a really solid foundation for representing data. Our use has been mostly internally focused, but as we've looked out to our 2030 strategy, we see opportunities for more digital diagnostics. I think COVID-19 has revealed that a lot in our respective organizations, how telemedicine and how we think about care delivery has changed. And so for us, whether we're building a new model, a new AI model to predict a particular diagnosis, of course, following all the FDA regs, ultimately underpinning that is a data standard, a data structure. And without that data standard and structure, it would be hard to offer that kind of service to another healthcare provider or even to a direct to a patient type of setting. So, our FHIR commitment has remained consistent. We see the value now starting. Some of the thinking we had for 2030 now is showing up in 2021. And we got to be thinking, how do we stand up these kinds of services and make them more interactive? And then finally, the last point, I think as we look at the consumer side of this, consumer choice, we've seen a variety of patient apps and mobile apps that get launched. We've committed to a patient mobile experience. It does leverage APIs, including FHIR, but obviously that is for patients that we have, but we see, a larger network of opportunity for that patient choice in terms of how they get their care, how do they seek out services, and how they have choice. I think all of which COVID has revealed aspects of that decision making. So I wouldn't say our strategy has changed dramatically, but it's put a focus on what might be coming next and how do we get there for certain types of, I'll call it, ecosystem interactions, especially around new types of diagnostic services and care delivery.
Yeah, and as you think about those different types of services, as people have different business models, so as you go from a fee-for-service business model to accountable care, value-based, where data outside the enterprise becomes more important and coordination with providers who are not connected in your systems become more important, does that accelerate your 2030 vision, or Dr. Ash, how you think about connectivity with those other systems, and what you both talked about specific use cases, maybe what are the use cases that become important in that world, or even payer connectivity in that world?
Well, I'll start with the diagnostic side. We haven't ventured a lot into the payer side yet. So, one of the principles of how these diagnostics happen, whether it's a cardiac system, a radiology system, sometimes that source system has their own proprietary algorithm. So how do you decode some of those specific things like waveform from an ECG? But then once it's in a more de facto standard, how to incorporate that into the FHIR standard. So, for us, we're looking at how do we inform standards, how we work with vendors to, I'll call it, liberate the data so it can be standardized. So then the larger community could take advantage of that. This is much like standards work. It's a slow process, but we believe that certain diagnostic services that we think we can offer, have some barriers of entry initially on those manufactured devices, but also we want to take that fact, liberate data, package it as part of FHIR, and offer that kind of service. So I think if anything, it's accelerated what we need to do and how we need to inform that. And we do have active projects both in our radiology space, our rad-onc space, as well as our cardiology space that has that kind of interactions going.
Great.
If you want me to add on, I think any of us that have not only a responsibility to provide extraordinary care to a state, a broader state, but also truly believe that we can provide service at a higher level than what may be available in a local market. As Jim talked about, anything that we focus similarly, which is one of the hot things, is the digital front door. Right now, there's so many entries into the system. And how can we make it more seamless for a person that, gosh forbid, but they need the transplant services or they need specialty oncology services? How can we allow them to shop, if you will, for what is the right location, what is the right service, while not being overwhelmed on the insurance and the administrative portions of that part of the transaction? And when a person is sick and when a loved one is suffering, the last thing you want to do is be worrying about if you can afford to pay for it or if your insurance will cover it. You should really be able to shop for what is the best services, the right services, and the services that make sense that are going to help my loved one get better. Not am I having to manage that trade-off, and am I going to be burdened with cost and expenses that are unimaginable? The early comment of Denmark, I have friends in Denmark through IT. This is a foreign thought to them. It's you go receive care. You don't go shop based on what you can afford and what you may be able to get covered by your payer. And so I think this will become a more seamless through price transparency. I think it will become more seamless as more and more people digitize. And I think we'll see better care for people and the citizens of our country as a result.
Yeah, that's fascinating. So you're talking about capitalism and consumerism and being enabled by these models, and then driving then even a broader, maybe telehealth kind of approach across different providers. So in the world that we're in today, with telehealth becoming more and more popular, you go to your provider, but imagine shopping and being able to go to a Mayo or Nebraska to get to your experts around those types of things.
Let's be honest, Jeff, you and I, when we grew up, people said the best hours were banker hours. And we said things that, the worst waiting room was the DMV. In my state, I don't even have to go to the DMV, or if I do, I have a check-in, and they're nice enough to notify me when they're running behind. And the last time I cared what hours my bank was open, I don't remember. And so now we need to move not to a waiting room where patients are waiting to physicians, but a waiting room in which the physicians and the health system are waiting for the patients. We need to disrupt those norms and quit accepting the way that it has been for years.
Yeah, I take pictures of my checks. I can't tell you the last time I went to a bank. I don't even know where my bank is anymore.
My bank's in another state.
I believe that. All right, let's go to our last question, and then we'll take some questions from the audience. All right, to take on a successful FHIR technology strategy for providers, what are the key focus areas and use cases for adoption? What are your build versus buy decisions? And how does the ONC final rule compliance factor into that? So Jim, let's start with you on this question.
Yeah, thanks, Jeff. I'll just give a quick history of our tech strategy. So in 2013, we committed to a theme of convergence, and this was led by two parts. One was our convergence approach to one electronic medical record system, this being Epic. Large implementation, multi-year, very successful. The second thing we converged on was around platforms, and so we committed to a unified data platform that was able to ingest, store lots of Mayo data, legacy data, as well as real-time new data from Epic for a variety of use cases. These could be analytic use cases, or they could be transactional use cases, clinical viewers, specialty apps, innovative apps that need to take advantage of data more real time. We built that. We were successful with Epic. We built the unified data platform. But we realized as we continue to look to the future, that wasn't sufficient. So I'll share with this group, we have committed to a long-term Google partnership. And as part of a build versus buy, we are committing to Google and their healthcare API of building on a longitudinal patient record. It's a shared vision of ours of that we want to have a scalable FHIR store that can store and persist lots of different types of data for our patients, but also think beyond that as we incorporate perhaps more patient networks or maybe even direct to consumer kinds of options. We accomplished a lot in our prior iteration, but we realized the amount of engineering, the amount of lift, it was even hard for us to keep up. And so we believe the partnership is both an accelerator for our participation, but also getting to us to the end goal of having data easily available and consumable. That's the ultimate goal here. In terms of some of the ONC rule compliance, we're really relying on the Google Healthcare API, which we're implementing release 4, but also Epic as they look at this same set of questions in terms of how the Epic FHIR APIs play with this. We believe implementing a FHIR server is not straightforward. We know there's all kinds of issues around out of order messages, reconciliation. How do you resolve this? And we've done a lot of that work ourselves at Mayo, and we've contributed some of that experience as well with Google and their collective experiences in dealing with this. So that's really been our plan going forward. We are now 1 year together with Mayo and Google. We are starting to flow data into our longitudinal patient record, but our intent is to replace our prior platform generations using the Google Cloud and some of the specific healthcare vertical components.
So what I heard you say was it's not just the FHIR standards, it's really data strategy and FHIR standards that then build towards the broader strategy of interoperability. One follow-up question for you, Jim, on that is third-party applications. So I consider providers some of the most technically diverse entities of any industry out there. One of our customers has 1,600 different products that they're managing in their data centers. And so from an interoperability perspective and a data strategy perspective, that's quite a challenge. What do you think is going to be required of vendors as you go forward and FHIR? And will your buying criteria around vendors center on FHIR, or will that become a minimum buying criteria for you?
No, great question, and I'll kind of break it down. You know, as we've seen sort of technology evolve in the healthcare setting, you know, first, our first kind of rule of order is, do they have an API? Any API you can connect with and interact with, or is it the typical, you know, interface, HL7 interface? So that is something collectively as part of our technology strategy and architecture. We push really hard with vendors in terms of the openness of their software stack. How do you get data in? How you get data out? The next level, of course, is do they support FHIR? Any aspects of FHIR as part of their standard APIs? For a lot of the integrations we have today, even though we reduced a number of these third-party apps with our Epic convergence, we still have some. And in many cases, they're getting data, I call it, from our enterprise FHIR services to consume data in to work with their system, whether that's a cardiology system or transplant system. That's been kind of the mode. But it is a criteria. We really push that point. Sometimes, you know, the market says that's all there is and that's what's best for patient care. So it's still that balance of, you know, technology modernization versus a specific need. And we have seen over time, the last 3 years, vendors improving that posture around first API interfaces, but also FHIR standards. So that's my best viewpoint on that.
Great. Kayan, any additional thoughts on that from the broader perspective?
Yeah, I think just echoing on what Jim said, I think we're seeing that common theme across many of our provider customers, right? I mean, I think the two key decision points for any provider organization thinking about implementing FHIR is, you know, the first one being, do you do this in-house? Do you build your own FHIR server? Do you manage it, or do you use one of the many vendors? And do you move to the cloud? Right? I mean, these are all big decisions to be made, and I think it comes down to what I mentioned before, as, you know, the 3 I's of our FHIR strategy. Right? I mean, if a provider system is doing this in-house, they've got to be thinking about implementing the FHIR standard, making sure it's scalable and performant, making sure that they're tracking the FHIR standard. Any changes have to be updated in the in-house FHIR standards. There's a bunch of maintenance of this, and also making sure it integrates with all the other applications, right? So the various hooks of, you know, taking in, say, HL7 video messages, transforming them to FHIR, exporting to a database or a data warehousing system. All these different hooks and connections have to be thought through. And so what we're finding is you know, our provider customers don't want to be in the business of managing this infrastructure and building out this infrastructure and supporting it. And once we stand up a FHIR server, it's got to be maintained for a long time. It's not something that you just set up and let it run, right? And so as one of the as one of the FHIR vendors, we would recommend to leave that to us, right? I mean, we think a lot about running these systems, scalable databases for privacy and security. And so that's one of the really important choices. The other decision to make is whether interoperability with FHIR is a short-term investment or a long-term view, right? So like Jim was mentioning, we encourage our provider customers to take a longer-term view. Unlocking the value of data, connecting these systems is usually just the first step towards a larger, intelligent environment that the customers want to build. Thinking about de-identification for research, for example, or building AI ML models for improving quality of care. So if the thinking is short term, there's always the option of bolting on, for example, a facade to existing data models and FHIRizing your data. But we encourage our provider customers to think about this more as a long-term strategic interoperability play rather than a short-term one. And then there's, to your point earlier, but Jeff, about knowledge sharing, I think there's a lot happening in the vendor community as well about open sourcing the various contributions. For example, HL7 B2 to FHIR mappings or CCDA to FHIR maps. We at Google have a healthcare marketplace where we're trying to bring together the various public data sets that could be useful for research, for example, or with the right consent of the various parties, eventually have shareable machine learning models that we can share across various systems. So we don't have to reinvent the wheel, right? I mean, so these are all, I think, choices that will help advance the state of interoperability. The last thing I would say is, as much as we as vendors can build the various products and systems and solutions, I think there's a very key role for system integrators here. There's always a last mile integration problem to be solved. Every provider implementation of Epic is slightly different. There's a combination of a variety of different systems that we have to talk to. And so, we work very frequently with other vendors and preferred partners to close that last mile implementation to make sure that this whole interoperability journey is successfully implemented at a provider.
Great. So we have 11 minutes left here. What we'll do is go to some of the questions from our audience. So I'd ask if you're an audience member and you'd like to ask a question, please get that in, and then I'll cherry pick a few questions because we have too many to answer in the next 10 minutes, but I'll try to go through as many as we can here. So there's two questions on normalization in here, so I figured I'd combine those together in terms of what your strategy is for normalization when it comes to FHIR, and do you have a normalization a product or approach to your overall FHIR strategy? I'm not sure if I'm addressing this question to Jim. Yeah, go ahead.
Yeah, I'll take a stab at it. Again, I think from our internal focus and use of FHIR, we've had to commit to certain reference sets for diagnosis procedures, lab orders, lab results, often drawing upon the standards like LOINC. And for us internally, that becomes part of the codification or normalization, as the question states, for us. It's been hard work. I think for us, our Epic convergence forced us to drive more coding system standardization than we were operating across EMRs. And so that work wasn't easy, but it complemented, sort of the timing complemented for us and how we use FHIR. Maybe I'll have Kylan talk about, more the broader interoperability around coding and code sets or normalization aspects of codes. But it is an important problem to deal with.
Yeah, just to add to what Jim said, I think we're finding that it's an absolute must in any of our interoperability projects, right? I mean, there's definitely terminologies, codes, data formats, the metrics and value systems. There's just a lot of harmonization that needs to be done. And a lot of this happens today in custom code that's being written at each of these various centers, right? There's just a lot of domain information there. We find that there's a lot of reinventing the wheel going on. So part of our strategy there is how do we give tools to the community and to our customers to make sure that one, they can use any standard mappings, but as we all know that there's standard is kind of a subjective term here. And so how do we make sure that there's a level of customization in there to eventually get to the solution for this harmonization problem without doing a lot of custom coding at the customer.
Great. So next question, and I like this question just because they use the word wicked in the question. We know there are organizational barriers to move forward with interoperability to solve wicked problems in healthcare. How do we include the patient in this mix, since healthcare data ultimately should belong to the patient and empower them to use it for their advantage?
I'm happy to comment on that. I think pulling in the prior question into this one, ideally, your codified terms using standard vocabulary sets go to a clinically unique ID that then allows you to map it to more human-friendly, more in language of first choice. And so I, as a physician, I'll use medical terms that you may not understand, right? And so how do I translate that into concepts that are more easy for you to understand and then more language appropriate? And I think if we perfected that flow, the questionnaires and the insight and understanding would be in your native tongue using a vocabulary set that is most comfortable to you. And then the reverse would be true. Whatever I enter clinically would also be translatable to something that makes sense. In the middle is where there will be lots of application development. If you are an athletic diabetic, the way that you want to look at your management of your condition is very different than how you're co-managing your child or co-managing your parent. And so I think the applications will become very, very tailored and will help you not be defined by your condition, but really live with your condition in a way that you want to.
Great. And there's another question here that follows up on this. It kind of takes almost exactly the opposite view of that question. So FHIR is so focused on patient-centric view of the data exchange. Would it help for better adoption if the focus is on a holistic healthcare data instead of centered around the patient? Dr. Ash, I'll start with you, put you on the hot seat on that one because you answered for the patient-centered view.
two in a row. I think anytime that we can create massive data sets, you're talking percentages of percentages of percentages. And so the more groupings that I can create to have better insight and understanding and customization of workflows, the better. And so, I'm in a health system in a state that represents 0.5% of the US's population. And Mayo is treating a very, very large portion. The number of patients on any given condition that Mayo has is going to be more than 10x. And so how can I make sure that I'm using the collective learning of not only the Mayos, but also the collective learning of people in other countries? And so how can I use those, CUIs or other clinical unique IDs to the map to the, the ontology and nomenclature within resident of that country? And so if there's people that only have a condition that's 1 in a million, the odds of me having any insight and information is very little. If I look at the entire world, the insight and understanding takes on a totally different lens. And if it's my child and my insurance would present to me options to go there, then I would feel really bad if I didn't. And so how can I present all that information in a way that is not only helping us from a physician clinical researcher perspective, but also from a consumer to create those patients like me, those experiences like mine, the people in the universe going through the exact same thing I am, and how can we work together to really change healthcare? And that wouldn't have been possible without digitalization, and it sure wouldn't be possible without standardization. And so we're on a journey that will completely transform the way we care for people and how we're cared for as individuals.
Yeah, let me provide maybe kind of a technical lens, so it's a great question. And so I think I divide it into two angles. One is, how do you represent the data and how do you actually use and access the data, like Dr. Ash mentioned. For us, one of our vision statement, needs of the patient come first. So ultimately, so many things revolve around the patient experience, the patient interaction, the data you collect on the patient. But then its use is about populations, it's about aggregations, it's about comparators. And so when we have built our existing FHIR as well as what we're doing at Google, we provide kind of both lenses, that of an individual, but that also from that of a population through additional query mechanisms. So Kylie, I don't know if you want to comment a little bit about that, but we want to enable both. It's not just a transaction at a time, but really supporting many uses.
Yeah, absolutely. I think we're seeing a variety of different use cases, right? So patient-centric use cases where the focus is on the patient view, but also just site-specific views or population-centric views of all the data that's in the FHIR system, for example. The other thing I would say is what we've found is FHIR as a standard is pretty powerful and extensible. Right? I mean, they've tried to capture a lot of the concepts that we have in healthcare. And where we see a lot of the real action happening is in these specific use cases. For example, like Karen's working on patient access APIs and provider directories and others. And Da Vinci is focused very much on value-based care and the provider-payer interaction. So I think we're going to see a lot of, patient-centric use cases are still the majority of the use cases today, but as these working groups grow and there's more of these use cases across healthcare that are being solved, I think we'll start to see more use of these other data, other resources in FHIR to solve like other healthcare problems across the industry, not just patient access.
So we're running short on time here, so I'm gonna wrap up and thank our panelists. I learned a lot from you guys. I thought it was great to get this perspective. I'm even more excited about the potentials for FHIR and what this could do for our industry as a whole in changing the way we think about care, coordination, and even the business models to deliver those things, and to get out from underneath the how do we deal with data to how do we improve care. This seems like the very foundation, the starting point for a real revolution for how can we really enable better care across not just a community, but a country or even the whole world as we think about that. And from the Cities Tech chair, where we do a lot of the integrations that Jim talked about, we enable FHIR solutions for our customers as well. We're seeing a lot of those same types of questions being answered, and people viewing this not just as a check the box on a regulatory thing, but really viewing it as a leap off to think about these broader strategies. And I learned a lot from you guys in terms of the art of the possible here, and even more excited than I was to begin with. So thank you very much, and thank you to our audience, and have a good rest of your day.
Thank you.
Thank you.
Yeah, thanks, everyone.